Thank you so much for the kind introduction. So I'm Sachan Mohan, and we'll be talking about latest advances in IBD today. And through this presentation, I hope to provide you with an update on therapies for ulcerative colitis and Crohn's, fistulizing disease, and the role of surgery. So I don't have any disclosures. Yeah. Is everyone able to hear me in the back? Okay, great. So the objectives of this presentation are to summarize the newest approvals in the IBD world, to share our current positions for ulcerative colitis and Crohn's, to review the surgical role, to flag the key safety considerations that we have, and to spotlight our local IBD program here at VHC. So I love history, and this slide actually summarizes the evolution of IBD therapy. And as you can see, much before 1930s, let's see if this is working. Not so much. So before 1930s, we did not have much of a therapy for inflammatory bowel disease, and it was the development of aminosalicylates in the 1930s and 40s that were one of the first molecules which were characterized to treat IBD. As of 2025, what we know that in mild ulcerative colitis, we can still use some of these compounds, mesalamine, but for Crohn's management, mesalamine has completely fallen out of favor, though sulfasalazine has a limited role in colonic Crohn's. 1950s was the time when corticosteroids came to the forefront, and due to their range of side effects, we don't use corticosteroids for maintenance therapy in IBD anymore. But in the induction phase, budesonide and prednisone do have some role. The 1960s were the age of immunomodulators, azathioprine, mercaptopurine, and I'm sure there are people in this audience who remember the landmark SONIC trial from the early 2000s that actually showed that anti-TNF therapy combined with azathioprine led to good resolution. But again, these molecules do intercalate with the host DNA, increase risk of malignancies, and have kind of fallen out of favor for the induction phase, though in maintenance there's still some role with anti-TNF therapy. The 1990s saw the advent of anti-TNF therapy. We all know who work with dealing with our IBD patients, trying to talk to the insurance companies, and anti-TNF is probably the first line we go to. But the data shows that about 40 to 60% of patients will fail anti-TNF therapy or be non-responders within 1 to 2 years of therapy. So the need had been for newer molecules, and much since 2010, we had several new molecules which have been approved and makes this field so interesting. So we have integrin antagonist, interleukin antagonist, Janus kinase inhibitors, and S1P modulators. So when I think of IBD, this is how I like to think about. So this actually shows you the signal transduction cascade of inflammatory molecule. And anti-interleukin therapy, anti-TNF, and anti-integrins, the ones in the red on this screen over here, are the main targets that we use. You can also see S1P modulators over here on the bottom right, which highlight the newer molecules which are being used. But the way this slide is relevant is because this highlights the newer approach in IBD where we are actually combining therapy. So as we speak, there's an ongoing trial, which is called the DUET ulcerative colitis trial, and where an anti-TNF therapy, golimumab, along with the interleukin therapy, gusculimab, is being used at the same time. And actually, the 6-week data shows about 87% remission rates. So in the future, there will be bigger role for combination therapy in IBD. Now, will that come at a cost of certain side effects? That's what the data will show. So the landscape of IBD has changed as of 2025. We have interleukin-23 class that has expanded across ulcerative colitis and Crohn's with approvals of risankizumab, gusculimab, and mirikizumab. S1P modulators have provided an oral option for our patients, especially using ozanimod in ulcerative colitis. And Janus kinase inhibitors have been approved in United States for people who have failed anti-TNF therapy in both ulcerative colitis and Crohn's. We know the molecule Rinvoq that has shown to work very well with the biological name upadacitinib. They do come at a certain boxed warnings for side effects of melanoma, heart failure, and thromboembolic events. And through the Society of American College of Gastroenterology and AGA, we have constant updated guidelines which are live. On the right, we again have the signal transduction cascade with the novel molecules, but I would like to draw your attention to SMAD7 antisense oligonucleotide. So this was a molecule that was being studied, but in the phase 3 trial did not reach the endpoint and was discontinued. But PDE4 inhibitor, people might remember phosphodiesterase inhibitors and Viagra. This is phosphodiesterase 4 inhibitor, and that has actually shown much promise and is currently being studied in a phase 3 trial. And in the next few years, we would have more data on this molecule. So with that background, I would like to start with my first case. So we have a 38-year-old female. She has a history of ulcerative pancreatitis. She is steroid dependent. She has failed Humira therapy, and she's coming with worsening symptoms of diarrhea, rectal bleeding, and abdominal pain. So how can we help this patient? So our current position for moderate to severe ulcerative colitis includes that in biologically naive patients, along with anti-TNF therapy, we can consider vedolizumab, which is gut selective, interleukin-23 inhibitors, risankizumab, and guselkumab. Whereas patients who have prior anti-TNF failure, Janus kinase inhibitors, Rinvoq remains an option, so the interleukin-23 inhibitors. And in patients who don't want to use injection or infusion and would prefer an oral molecule, S1P molecule inhibitors, etrasimod, ozanimod remain a viable option, though they do come with a certain risk profile of cardiovascular side effects. Patients who need rapid symptomatic relief, Janus kinase inhibitors can be considered, though we have to talk to the patient and consider the overall risk. So the latest approvals in the world of IBD have been risankizumab, guselkumab, and mirikizumab. They were approved within the last 2 years. And the Varsity trial is a very landmark study that actually compared vedolizumab to adalimumab and showed that at 52-week interval, you had both an endoscopic as well as histologic remission with vedolizumab or Entyvio compared to adalimumab. And that actually took adalimumab completely out of management for ulcerative colitis. So coming back to our patient who is failing Humira therapy and is steroid dependent, we had an in-depth discussion about interleukin-23 inhibitors and Janus kinase inhibitors. The patient did decide to use interleukin-23 inhibitor risankizumab. So this is a shared decision that we have to make. And the way we treat these patients has changed because now we treat to target and with a plan to scope the patient within a 6 to 9 month interval. And in coming slides, I will talk more about what treat to target entails. Our second patient is a 26-year-old male. He has a history of visualizing Crohn's disease, and he has tried Lialda, Canasa, and steroid enemas through different providers and has no response. So how can we help this patient? And our current position for management of Crohn's disease include that in biologically naive patients, we can use anti-TNF therapy, ustekinumab, or interleukin-23 inhibitors. In patients who have had anti-TNF failure, interleukin-23 inhibitors, ustekinumab, and Janus kinase inhibitors remain an option, while in patients who have had prior anti-TNF exposure, in head-to-head studies, risankizumab was shown to be superior to ustekinumab. If person has a stricturing or inflammatory ileal disorder, then surgical option becomes the mainstay and should be offered first. So this is industry-based data on mirikizumab or OMVO, and it actually shows that in both biologically naive patients as well as in patients who have failed anti-TNF therapy, OMVO showed statistically significant response. Though if you were to ask me, I just feel that this 40-45% response in the placebo arm is probably a bit too much for my comfort level. This is another molecule that was approved recently as of March 25, that is guselkumab. And guselkumab also showed remission at 12-week interval clinically as well as endoscopically. The benefit of guselkumab also is that this can be used both as a subcutaneous as well as an IV induction medicine. This is the landmark Seaview trial where they compared ustekinumab and adalimumab, and this was a non-inferior study, and both were shown to be effective. And we should talk to our patients and see, based on their risk profile and preference, what are the options they want to use. What about perianal fistulizing Crohn's disease? The data shows that these can be diagnosed by using MRI pelvis and exam under anesthesia. Seton placement and drainage is the first line with anti-TNF therapy, and there has been a lot of promising data that shows that using antibiotics with anti-TNF therapy leads to better outcomes. Again, we have to optimize the infliximab in these patients, and we have to follow a multidisciplinary pathway. The diagram on the right is from Dr. Gary Lichtenstein's work in Philadelphia that actually shows the infliximab is superior to placebo in these patients. What about patients who have failed anti-TNF therapy? Studies from the Europe have showed promise with allogenic mesenchymal stem cells. Though phase 3 studies in United States did not reach their endpoint and were discontinued, in European Union, stem cell therapy has been approved. Now, the idea with the stem cell therapy is that you are pretty much replacing the inflammation-producing cells with new host cells that will not participate in the inflammation cascade in the same way. So, however, in United States, in patients who have failed anti-TNF therapy with a fistulizing disease, we can use ustekinumab, vedolizumab, and interleukin-3 inhibitors, and we have to approach it via a protocolized pathway. What about patients with enteroenteric and entrovesicular fistulas? So this is a complex disease, and these are the patients who would need surgical therapy, though there is data that after surgical therapy, there is a role for biologics in a regulated way. So what is the role of surgery in Crohn's? I can't say much about this because my colleague, Dr. Rezak, is going to come and blow us away. But as a way of his introduction, so in localized ileocecal disease with symptoms, complications, ileocecal resection is reasonable. This can be cost-effective option. It does improve the quality of life. However, we do have to consider a post-operative biologics in these patients too. And this is a very significant study that was published in Clinical Gastroenterology Hepatology about 3 years back that actually compared in a randomized way in post-surgical patients the role of infliximab compared to placebo. And infliximab actually showed a lower recurrence, faster remission, and more sustained response than in placebo, in which biologics were not used. So we have to risk stratify our patients. We definitely offer them follow-up colonoscopy after surgery at a 6 to 12-month interval. And in other options other than anti-TNF remain ustekinumab, vedolizumab to prevent post-operative recurrence. So coming back to our patients, we offered him MRI pelvis with exam under anesthesia with Seton placement. Patient was initiated on infliximab with antibiotics through therapeutic drug monitoring, and we did give him an option of escalating to interleukin-23 if he fails that. So what do we know about safety with these advanced therapies? So serious infections is always a concern with the anti-TNF and biologic therapy. However, vedolizumab is slowly gaining more ground in this field. It's more gut selective and has a better profile. Janus kinase inhibitors are extremely effective, but they do come with a side effect risk of cardiovascular diseases, thromboembolic events, and non-melanomatous lesions. Vaccination is extremely important in all our patients, and we have to mitigate our risk by talking in detail about vaccinations, routine blood work. What about the malignancy concern for these medications? So we always knew that thiopurines were increasing the rate of malignancy in patients, and that's why thiopurines have been taken out for induction. If we consider the newer guidelines from Dr. David Rubin from Chicago in ulcerative colitis and Dr. Lichtenstein for Crohn's disease, thiopurines have fallen out of favor. And anti-TNF alone does not cause as much increased risk in malignancy, but when anti-TNF is combined with thiopurines, the risk definitely goes up. So far, there's no clear data on vedolizumab, ustekinumab, or risankizumab. What about pregnancy and inflammatory bowel disease. So I can tell you, I've personally had about 15 patients in the last few years who were pregnant and who had colitis. And whichever religion you believe in, you have to pray to that God. And uh, the data shows that anti-TNF therapy is safe. The data shows that there's no teratogenic effect to the fetus. So we do continue anti-TNF therapy for the course of pregnancy. Other molecules that have shown promise is vedolizumab and ustekinumab. We do hold the live vaccines once the infant is born for a period of 6 months. This is a very important slide about the STRIDE-2 trial. The STRIDE-2 trial actually changed the way we think and manage inflammatory bowel disease. Prior to the STRIDE-2 trial, the approach to an IBD patient was that we look at the patient, we wait for the patient's symptoms to worsen, and once their symptoms are worsening, we actually escalate therapy. The STRIDE-2 trial actually emphasized that we should consider a treat-to-target approach where the goal of IBD treatment is endoscopic healing, and non-invasive ways like fecal calprotectin levels and intestinal ultrasound should be incorporated. So here, once we start the patient on therapy, we are chasing endoscopic healing and normalization of fecal calprotectin level. And that gives more personalized treatment, and we can ramp up our approach based on patient's clinical trajectory. So what about our IBD program here at VHC? So we are striving for rapid access clinic slots for our patients within 3 to 5 days. We have in-depth IBD multidisciplinary partnerships with colorectal, hepatobiliary, and our foregut specialist. We are looking at therapeutic drug monitoring, imaging protocols, especially MRI pelvis, and participating in multidisciplinary settings. The outcomes that we are tracking is time to biologic therapy, because much of the recent data shows that sooner we start our patient on the right fit biologic therapy, the better response we have. The data would show that this should be as soon as 6 weeks, which in practice sometimes can be hard to achieve. We are also looking at steroid-free remission at 6 to 12 months. We are looking at fistula healing rates and the post-op recurrence rates and adherence to a 6 to 12-month colonoscopy. So take-home messages from my presentation for today. Interleukin-23 class has emerged as a first and second line option. Anti-TNF is the cornerstone for perianal disease. Early surgery is reasonable in localized ileal Crohn's disease. We do have to consider ways to prevent post-operative recurrence. Safety matters, talking to our patients, coming up with a plan for immunization matters. These are my references, and I would like to thank everyone at VHCGI. Thank you.